Okay, thank you very much. Just to check, are we able to see my slides?
Yes, we see it very well.
Perfect.
So our next speaker is Zachary McCarthy, who will talk to us about, let me check again. So you will talk about a data-driven model-based approach to infer shifts in social contacts patterns during an evolving pandemic. Is that right? So it's okay. So I missed your title page. Sorry. Right. So Zachary McCarthy from York University, and go ahead whenever you're ready.
Great, thank you very much. So thanks for having me and thanks for the invitation. So extended to all the organizers. So hello, everyone. So as mentioned, our group's been actively engaged in modeling COVID-19 in Canada, and I'll be presenting one of our group's publications in this light. So I'm speaking here, but there are many great people behind this work, led by Professor Wu, Professor Jianhong Wu at York. And as mentioned, I'll be presenting research that's been published in Journal of Mathematics and Industry. And just as a note, our home base is primarily at York, and we have collaborators throughout and are members of the Mathematics of COVID-19 Task Force, the National Task Force in Canada. So just to begin, on the right here, I'm displaying the confirmed and probable cases in Canada according to province. And so in response to the pandemic, different interventions have been implemented to either mitigate or suppress transmission. And the goal is to limit the burden of disease. And these measures take form of, say, community-based measures like closures and limiting the size of gatherings. And these are also in the form of personal or individual measures, so more hygienic measures, or respiratory etiquette, face masks, etc. And what we really aim to do in this work is, while the measures were put in place, to what extent primarily do the community-based measures have to alter the mixing profile. So the social contact mixing. How do people mix with different people in terms of maybe their age? And the heart of this work aims to really quantify these effects. And to address this question, so we develop a general framework that accounts for different key epiparameters. And in particular, we look at the age stratified susceptibility to infection and the location specific mixing. So we look at mixing, contact mixing in workplace, household, school, and community or leisure settings. And we assess the transmission acquired in these 4 settings. And the methods in the framework that we present here are general, but we've applied to the province of Ontario. And on the graph here on the bottom right, we see carefully chosen dates. And this is the confirmed cases in the province of Ontario, which is a province in Canada, by the way. But the end of the date here, so May 19th, marks the reopening. So there was a staged reopening where some measures were relaxed. So our analysis is purely during the escalation of interventions. So the specific measures that were put in place in Ontario were, we really break down into 4 distinct phases. So monitoring and travel advisories. There was a public school closure in the province. Following is a state of emergency and distancing advisories. And later is a non-essential workplace closure close to more representative of what you may think of as a so-called lockdown. So the strategy for our work really break up into 3 segments. And first, we introduce a transmission model, which will be the heart of our study to assess the impacts on NPIs or non-pharmaceutical interventions on the mixing. And so second, need to identify a social contact matrix representative of mixing in the province. So how do different age classes mix with different age classes? And lastly, so third, so how to put these pieces together and to capture the effects or the different interventions with the transmission model and the senses that will absorb the interventions into a phase-dependent or time-dependent contact matrix. To introduce the transmission model, we have the model diagram listed on the right. So this is a mechanistic model with a discrete age structure. So individuals are susceptible to infection. And just to go over the basic sense of the flow of the model, so individuals are susceptible, those that are exposed to the virus and escaping contact tracing later develop symptoms and move to I, or remain asymptomatic and simply are removed from transmission. And those who develop symptoms may be diagnosed as a result of these symptoms. Similarly, there are individuals also who are identified through contact tracing and diagnosed as well. So we have several key age-dependent parameters here. These are the susceptibility to infection. We have diagnosis rates, and of course, the contact matrix. And as a note here, we display 2 copies of this flowchart to denote the relationship between the different age classes. So we have SIs and SJs. So we have 6 age classes in this model. So these are 0 to 5, 6 to 13, 14, 17, 18 to 24, 25, 64, and 65 and above. So the reason we choose these age classes is because these are representative of, say, daycare ages, primary school ages, high school, university, and maybe young adults, the workforce, and seniors. And on the bottom left here, you see one way to write down the model equations. So this is our transmission model. Now we need a contact matrix for the sort of second in our series of steps here. So in previous work, it was addressed how different age classes interact with different age classes in terms of their setting-specific mixing. So these were projections from reference 5 here, from this work in computational biology. Since here we have our household contact matrix, workplace contact matrix, school contact matrix, other locations, and the sum of the 4 represents mixing in the bulk. And we will use these, so just a bit of context. So reference 5 is using the original data from the seminal polymod study. So now that we have these established results, we can obtain mixing in Ontario. And we'll apply a series of transformations using demographic data in the province. So there's a few requirements for us to integrate the contact matrix into the model. So we modify the age classes. So in our structure, in our setup here, we have 6 age classes instead of the standard 15 or 16. Second, we'd like contacts to be reciprocal in the sense that the conservation law, so contacts received must be given and vice versa. This is called reciprocity. And We also account for the Ontario demographic profile, and the contact rate is adequately altered to represent mixing in Ontario. So on the right here is our answer to this series of requirements for the contact matrix. So we have the mixing in the household, workplace, school, community, and other locations, as well as the sum of the four, which is all locations combined. So this is our really baseline matrices in a peaceful time where no major distancing measures are put in place. So now that we have this mixing profile, we wish to capture the effects of the non-pharmaceutical interventions. So we'll use our 4 settings of contact as building blocks. So recall we have our 4 phases of interventions. So we will model this using a time-dependent contact matrix. So this is piecewise continuous with more time-dependent contact in the final phase. So how exactly do we do this? So in the first phase, we have CH. So by the way, a bit of notation, CH denotes the household contact mixing, CW is the workplace, CC is community, and CS is school. So in the first phase, there's no major measures put in place. So we simply take the sum of the 4 settings to represent mixing. In the first phase here, there was a public school closure. So we take 0 contribution from the school mixing, and we have a shift. So we introduce 2 parameters at this stage, P1C and P1H. So we model a shift to the community contact and a shift so an increase also in household contact. In the second phase here, we have distancing advisories and the state of emergency. So in this light, we model a reduction in the community contact and a further increase in the household contact. So very similarly, one more time, for the third and final phase of escalation in the province, we model a time dependent, so we have an exponential decline in the community contact rate, or the weight associated with the community contact matrix. And similarly with the workplaces, we have a decline in the workplace contact, and we model a increase in household contact. So we choose a time-dependent contact weights in this final phase to model the society really taking time to adhere to these measures. These were the strictest measures put in place. Now all the ingredients are put in place. So we use the age-stratified case data to parameterize this model. And these include, so the parameters being estimated include the weights that were introduced. So we fit the model to the cumulative reported cases. So displaying here the model fit. So these are the 6 age classes mentioned before, the cumulative incidence. And all 4 phases considered are being fit simultaneously. So the red dots denote the data, and the blue dots denote later points. And the gray region represents the 95% confidence interval from the fit. So we, to address noise and really quantify uncertainty, we assume a Poisson error structure and refit the model 1,000 times to different realizations of this case data. And so the reason we display these blue points here is because that prior to the reopening, we believe there was mixing among the younger age classes. So notice that those that are 65 and above, so the senior age class, these cases follow the expected model trajectory But on the other hand, the younger age classes, the remaining, do not. So there are more cases in this group than the model expects or the model projects. So we're speaking about the interventions, but before unpacking the results, I would just like to note that the interventions put in place were estimated to be effective in reducing transmission. So I'd like that to be clear. But we do estimate that the effective reproduction number drops below 1 somewhere between April 5th and April 12th. So in our final phase here. So we calculated RT with the next generation method and the next generation matrix and our transmission model. So informed with the estimated model parameters. So now we can unpack our results here. So recall that we introduced these parameters associated with the contact matrix. So what that allows us to do is we can, in fact, calculate the contact mixing in each phase. So we have the contact matrix in phase 0, in phase 1, in phase 2, and the end of phase 3. So we choose the end because this is a time-dependent contact matrix. And really what we know here is that the household contact pattern emerges. And this is an agreement with prior works and is an agreement with, this is logically sound, right? And so other works that have explored this and also found this are more participant-based studies. So in other words, in lines with the polymon study where participants are asked about the location and the number of contacts that are made with different age classes. So this household pattern emerges. That's the key point. Now we can unpack more. So using our estimated contact matrices, we can use the so-called, so we can compute the so-called mean connectivity. This is the average number of contacts per individual over the whole population. So the sense is that given a contact matrix C, and a population profile and I, then the mean connectivity or the average number of contacts can be calculated. Now on this this left-hand panel here, we can see a graph for the mixing in 4 different phases. So we have the household, the community, the household, workplace, community, and school mixing by average contact number. And then in the remaining phases, so in the 3rd phase of escalation here, notice we have time dependence. So the community contact drops exponentially, as well as the workplace contact. And it's interesting here, the household contact is not altered substantially. So by contact number, we also see a shift to the household. And we can also display this by more numerically. So the total contact rate per person, so the mean connectivity of the phase 0 matrix is about 12.3 contacts per day estimated. And in the final phase, the contacts drop to about 6.5. Okay, so we stratified by contact number by phase and by location. So we see the biggest drop in the contact following that non-essential workplace closure, that so-called lockdown. Now, still continuing to unpack this fit. So since we have the mixing in each phase, we can track the infections acquired in each setting. So we can do this by introducing, so we can sum the inflows of the newly exposed individuals and add these compartments to the model. So we add 4 different compartments to the ODE, and we can solve the ODE to calculate the number of new infections. So what I'd like to point out here is in this inset, we have the that initially, so early on in the epidemic, the community initially played the primary role, contributing to infections, then workplace is the green, followed by household, and the school contributed the least. Okay. However, after more measures were put in place, so after March 24th here, what we see is a shift in this behavior. So the primary contributor after March 24th is the household, followed by the community settings. So as a special note, the school was estimated to contribute the least to infection early on. So I know that's a major question and a major element for us to consider at this time. So very briefly, just like to mention that we can visualize these results different ways. So we can see on the top panel here, the cumulative infections by setting, and we further stratify by age class. So we have the workplace setting infections, the household, the community, and schools, finally. So this is further stratified by the ages in each panel. And so on the bottom, we're showing simply the reverse of this. So this is infection by age class. So we have 6 age classes. And then further in each panel by the setting. So we'll have 4 settings in each panel. So what I would like to take a special mention of is the senior age class, estimated to acquire most infection in the household and the community here. So we also estimated the susceptibility to infection, and this increased with age, as we would expect, and has been done with in prior works. And I will note prior works using different methodology. So this is both modeling studies and more epidemiological studies using, say, infector-infectee pairs and looking at data. So we have the susceptibility to infection increasing with age. And we also estimate the percent of symptomatics that are diagnosed, which we also estimate is overall increasing with age. So this would be an expected result because the severity of illness is expected to increase with age. So another way to think about this is proportion of individuals with risk factors may be increasing, and these are expected to be caught in the surveillance system by proportion. So these cases. So on the bottom right here, would also like to note that, so these are the empirical distributions of the estimated susceptibility to infection according to age. And so the shape here indicates that the estimates for the susceptibility are robust to noise in the case data. So this is a report for this write-up in this publication, and there's several caveats to consider. So first is the reported cases. These are subject to error, and we address this with an uncertainty analysis and assume this Poisson error structure to refit the model. Also, along these lines with the case data, so early on in the epidemic, only symptomatic individuals were tested, and later the capacity, so the testing capacity was enhanced, and those not presenting symptoms that felt they may have been exposed could receive a test as well. So the testing protocol was changed. So there are heterogeneity in geographic location. So Ontario is composed of many different, so 34 different health units, and one of these is Toronto, for instance, which is a large city, one of the largest cities in North America. And so most of the cases in the province are located in Toronto. So lastly, I'll note that a large proportion of, so a proportion of the cases are those associated with healthcare and long-term care homes. And these specific settings were disproportionately affected, and the current model does not account for transmission acquired in these settings. So it may be better. So these are some caveats to consider. A few conclusions, closing remarks. So in this work, what we do is we retrospectively assess the contact shift in the presence of evolving control measures. And really would like to note here that the non-essential workplace closure, that so-called lockdown, seemed to have the greatest impact in terms of reducing the contact. So we can also use the framework proactively. So this is a framework for evaluating reopening measures and in terms of 4 settings of contact. And a major item at this point in time is also, so the framework can weigh vaccine distribution strategies. So effective vaccines or efficacious vaccines have come to light, and the vaccine priority, so beyond these first rounds, may be less trivial. So a framework such as this may be helpful in this situation. So I would like to note here that the heterogeneity may make this vaccine priority, so identifying the ideal vaccine priority may not be so trivial, because we have heterogeneity in susceptibility to infection and activity levels. So the individual contact rate by age is also varies quite substantially. So that 65 plus class, although is most susceptible, the activity levels are relatively low in terms of the known contact mixing data. So lastly, or just to wrap up here, so this is a data-driven approach, as the title suggests. So we can provide insights into the contact mixing purely from surveillance data. And we can do this on the fly, close to real time. So that's a new component of this study that I'd really like to highlight. And in this light also, so the method can be applied in many regions. So this method we lay out really begins with alteration of contact mixing matrices adopted to a specific region. And these matrices and the case data, as well as demographic data to conduct the analysis, is largely available worldwide. So there's a few projects in progress from our group. So first is a comparative analysis between Toronto and the rest of Ontario. Also looking at optimal immunization program. So really these items show the immediate application of the framework. And so third is to assess the impacts of relaxation measures. So how does the setting-specific contact mixing profile change as interventions are not put in place, but are eased, and we open, say, partially opening the schools? So just to note here that this framework is relevant, again, for the retroactive and the proactive. And we are currently working with with a number of different government agencies for projections. So I've not listed this on here, but also looking at displaying our projections on a web page, a web applet. So that's not entirely related to this age structure model, but wanted to mention because I think this is an area that's emerging as important to communicate results in close to real time with public. So I'd like to acknowledge project support from CIHR, and also Professor Wu is a member of several expert panels in Canada and Ontario, as well as the reference list. So again, I'd like to thank you all very much, and I'm happy to take any questions.
All right, thank you, Zachary, for a very interesting talk. So now, is there any question in the audience? So I saw some reactions on the chat. Okay. So correct me if I'm wrong. Oh, Melanie, you have a question?
I mean, you can go first if you want. I don't mind.
So just a very quick remark. So your analysis, the analysis you presented here is based on the first wave of COVID epidemic, right?
Yes, yes.
Did you try to apply the method to the second wave by any chance?
So this is an item that we're working on currently.
Oh, okay.
Yes.
Okay, well, thank you.
So one of the issues that is important is to really estimate what's really the contact mixing in the school, because the school were open in the second wave, but the contact mixing should not be the same as pre-pandemic. There are some social distancing and some change of curriculum. And this is very important because all schools in Ontario are currently being closed. So we are talking whether the school can be reopened after our second lockdown and to avoid a third lockdown. So yes, this is really something very important to do this for the second wave, partially because the contact mixing during pandemic and before the pandemic were so different. Even the facility next school is open.
Okay, okay. You mean there was some critical differences between the two lockdowns? Or
no, the first lockdown in Ontario was simple. We started with closing the school because we started everything because the March break in Ontario just right happens to the province took the opportunity to shut down the school first, and then progress to state of emergency and then closing all these non-essential business. That's how it goes. Social distance was escalated. De-escalation is reverse directions. So you open the school first. You reopen some non-essential business and reopen the school. So the contact mixing you identified during the first wave would not be applied because the school was open first.
All right, thank you. So I think Melanie was first, and then Jeffrey has a question.
Thank you very much for your talk. It was super interesting. So I had a question about, so you mentioned a little bit about severity and the assumption that with age, there is with younger age, there is a decreased severity, which is probably linked to a decreased transmission, which has been shown to some extent, but there are some variation of it. And I was interested in knowing how robust are your results to this assumption, and also how would it change the transmission matrix, and especially because with the new variant we may think that the younger will be more contagious also. So how this assumption impacts the results you found?
Right. Thank you for your question. So maybe it would be good if I maybe clarify exactly the result that we state here in this work. So here, just displaying the result mentioned. So this is the percentage of symptomatics that were diagnosed. So the sense here is that these estimates are increasing with age, and the sort of the logic behind this, or our thinking behind this, is that typically cases are expected to be more severe as age also increases. And maybe a way to state this is that the proportion of individuals with these risk factors increases with age. So there are cases that are more likely to seek healthcare, right? So this was particularly the result. But does this help with your question, or I feel like it didn't quite get to the heart of it.
No, the question I think is related to the transmissibility with the new strain. So that would require you modify in your model, I think, the transmissibility coefficient. And it's something to do with this, but this one is changed.
Yeah, exactly. My question was like, how do you actually estimate, did you actually estimate it or fix the susceptibility to infection? I think that's the parameter of transmission, right? Is it this parameter that you use to evaluate how the transmission by age class?
Right, right. So I can also, maybe also good to mention this. So the transmissibility is the same, is assumed in this model to be the same for all age classes.
That was my question.
However, yes, so that's a major assumption, yes. So we do not estimate this. I've actually not seen too many works looking into this, but the susceptibility to infection, so the probability of, that probability on contact that an individual does acquire infection, this is the parameter that we do estimate, yes.
Okay, but you assume that the transmission is the same for each age class?
Yes, yes.
Which is probably, which is discussed at least in many papers. And so my question was just the robustness of your result to this assumption.
Right, that's a good question. And actually, that's not one that we've explored in great detail. So I don't have a very good answer, but I would say that this is an important aspect and a major assumption in model, in particular this model, and at least the scope of the modeling works, or the modeling works in this scope of this SIR type model with age structure and transmissibility. So that's a major assumption in many of these models. So I think this is an important aspect. So getting a handle on just my take here, an instant reaction to elaborate a little bit, but getting a handle on transmissibility, yes. So that's so in terms of modeling, that's a good question to think about. So it's not immediately obvious how to, at least to me, how exactly to do that.
Thanks.
I think Jeffrey Harris has a question.
First of all, I think your results are very reasonable. In fact, I put on the chat a citation to a paper, an SIR type model, heterogeneous model with 2 age groups, which estimated from incidence data exactly the point you're making, that the contact matrix in effect is highly asymmetric. One issue is the interaction between social mobility on the one hand and contact within the household on the other. What I have found is that the younger people in the household are socially mobile, they go out to work, they go out to eat, and then they bring home the infections to the remainder of the household, which is basically locked down at home and doesn't move at all. And I put another site on the chat basically suggesting that in some areas, not necessarily Ontario, intra-household transmission is a critical factor, especially when you have multi-generational households. When the young person comes into the household, and it's not just the parents, it's also the grandparents, aunts, and uncles. 1 or 2 key places in the United States where that happens would be Los Angeles County, where the percentage of multi-generational households is probably closer to 25 or 30%. And the other is the classic case of New York City.
Yes, so thank you for the links, and that's a fantastic point. That's a fantastic point. Was there did you have any specific question about that? Or just a comment?
No, I just wanted to make that point. I thought your results were quite reasonable, and I think they are. I didn't see in the references a whole lot of papers that actually, in fact, support the findings you have in Ontario. But I think they're there.
Jeffrey, it's
Yes, thank
also
you.
the multi-generation household is exactly what this whole project was eventually started before the pandemic. So we were working on the influenza, but I think it's more important for COVID-19 is in the multi-generation household in Canada, in Ontario, this particular given Canada is such an immigration country. So multi-generation household is a large proportion of among the household composition. And when you open the school, so one of the major consideration is the seniors in the 3-generation household, for example. What would be the impact if you're talking about the safe for the kids, given the relatively lower transmissibility, and this might change given the new strain, but the impact is really to the seniors who are staying home. So yes, it's multi-household generation structure in Ontario is something we are trying to construct. We have some work on this and before the pandemic, and it will have impact during the pandemic because the time of family staying together is longer. So this is a really good point, Jeffrey.
Let me just add, I think I heard the point about the new strains. Unfortunately, I'm thinking that this is changing all the rules, and analyses that we've done about the first, second, and even third phase turn out to be important and enlightening, but don't help us too much talking about the future. And although the strain from the UK and Brazil and South Africa are in the news, it seems to me the most unusual case is the recent paper by Jasmine Plummer and Med Archive about a new strain in California, where I am right now, which seems to be the only explanation for the explosion of cases in Los Angeles.
Right. So the same years in Ontario, we had a large outbreak in long-term care facilities. It's because of new strain. So the government had intensive testing, and unfortunately, it's all because of the new strain. So the data is coming out. The news is already coming out, but I think the data has come out very quickly.
So, all right. Well, is there another question? So I see there was a remark by Melanie in the chat. So maybe now would be a good time to close the session. So let me thank again the speakers of both sessions, so Annabelle and Melanie, and also Zachary, for very interesting talks. And so I hope we'll see you in the next session of the webinar. Right. So good day to you all, and see you next time.
See you. Thank you.
Thank you. Bye.
Yeah.
Bye.
Thank you, everyone.